in trying to talk a little bit about the cost effectiveness and who should pay what, one of the things I want to discuss is the things we don't know, but also some of the things that it probably doesn't matter that we don't know, but that might be a slightly different theme. So I'm going to start off just with a few thoughts about, is palliative care about specific services, or is it really a system of thought? And moving on to looking at some of the challenges in assessing cost effectiveness in complex services, and particularly in the area of palliative care, and looking a little bit about what the evidence, insofar as it exists, says about this, and then getting on to what I think are interesting questions about how we should pay for palliative care and who should pay what. And then I'll end up with my more research needed, which is called concluding remarks. This is a kind of obvious set of points I want to make. My father always said to me that he didn't teach me much, but he taught me to understand simple things, and practically nobody in the world understands simple things, so this was a great advantage. Sometimes going back to simple questions I think is useful, because I was just trying to muse with myself, could anyone stand up in a public forum and say, is surgery cost effective? Oh, I'm not sure. Is surgery cost effective? Well, maybe. And then of course you disappear into, well, there are 4,000 kinds of surgery and lots of different things, and 4 million different kinds of patients. It doesn't make any sense to say, is that cost effective? But a lot of the discussion about complex services, and palliative care being really the ultimate complex service, seems to ignore the fact that you can't ask that question. You can only start looking at specific types of things for specific types of people to see if they make sense. And that doesn't mean that we can't generalize from evidence from one group about the likelihood of it being appropriate elsewhere. But I think we can fall into the trap of thinking somehow we can get answers to questions that are inherently far more complicated than that. And we need to be focusing, I think, on understanding the complexity of what we're trying to discuss. I think some of the change in the way of thinking is what everyone has been describing, and it appeared in the discussions this morning. It's really about, embracing the complexity and treating the person. It's all simple ideas, but I think it's very important to come back to this is the sort of thing we're looking at. So we're interested not in disease, but we're interested in consequence. And I'm always reassured by the notion that I'm almost certainly going to get prostate cancer. I'll certainly get it if I live as long as I want to live. And it's going to be a sort of cause for celebration when I get prostate cancer, because it will show I've got old. And I'll have got very old if I'm absolutely certain I'll have it. And I don't care so long as it doesn't do me any harm, which it probably won't. But I'm just giving this example as, it is part of the change in thinking that we're looking at. But there is considerable evidence that palliative care services of different types in different places for different groups are greatly valued by those who receive them. And I'm going to be talking a little bit about that in a minute. But the challenges in assessing cost effectiveness are common, I think, in all complex areas of healthcare, which is kind of depressing in a way, because the whole system of thought grew up where you were looking at very linear, very simple, very straightforward interventions, like, does cataract surgery make you see better? And the answer, you'll be glad to know, is cataract surgery does make you see better, and it's quite cheap to make you see better, so it's a good thing. And it probably improves your quality of life by quite a lot, because seeing better is a good thing there. But it's incredibly simple. Hip replacements make you walk better, and you can measure that. And people smile more when they walk better, and you can measure some of that as well. These are really simple things. And then we try to get into understanding highly complex sets of problems. Typically, multimorbidity has been in play some time before you're getting into the period where palliative interventions are taking over in the primary role. And people are then trying to do similar kinds of assessments, saying, does it improve functioning and quality of life? And trying to use measurement tools that have grown up around, can you see better? Can you walk better? And I think the great thing about doing research in palliative care is it basically makes you look at all the other research people do and start questioning whether they've got their sums right as well. Because once you start embracing the complexity of the problems and the objectives of treatment and the complexity of people's different needs, you get away from the notion that a scale of 1 to 10 saying, how's your eyesight, is probably going to be pretty inadequate in understanding the effectiveness and the cost effectiveness of that intervention. And that's why I've been interested in trying to embrace the agenda of trying to assess cost effectiveness, looking more broadly at what people want, what do they value, how do they express their preferences for particular approaches to care, rather than trying to measure using very simple scales and trying to work from that. But that has obvious challenges because the person doing the cataracts can still come back and say, look, I can get these people to see, they couldn't see before, I've done it, and here it is, and it's great. And of course, it is great, so that's straightforward. So I think the challenge we're sitting here with is that in order to make any sense, we need to be embracing the complexity. But if we do that, we're challenging the general paradigms for how we set priorities across different areas. And some of the discussion this morning, I think, really emphasizes why this is a problem. Because as we are competing for resources, the more plausible you can be, the easier it is to argue to gain and retain the shares of resources that are available. And the easier it is, when things are hard to measure, to say, we've got no evidence that that does much good, therefore, why should we bother with even trying? So I think there's a real challenge we're going to be facing there. And the tools that have evolved so far have evolved very much in the context of relatively simple objectives for relatively simple problems, where the overlay of complexity of multimorbidity and multiple objectives of treatment have typically not been to the fore. But we do know a lot about what people want and what features of palliative care they want. For example, they want easy access. And the evidence is overwhelming that they want hassle-free, easy access. They want access to effective interventions to manage symptoms when they want to get that access. And it's very clear, to the extent, how many people in here have got degrees in economics? Apart from Paul probably has yes, a few others have. So you would understand what I mean by lexicographic preference orderings. No, you don't, you've forgotten that. Of course, a degree in economics is a statement of how much you used to know. But the lexicographic preferences is where you're not willing to think about something until something else has been sorted out. And there's quite strong evidence around palliative care that people are very interested in hairdressing. But they're not interested at all in hairdressing if they think it's a trade-off with that or getting good access to competent professionals to manage the symptoms that they're concerned about coming up and being appropriately managed. So we've got good evidence that people want good, easy, hassle-free access. And they do this in the context of a hierarchy of the way they think of their needs. And this has the implication, I think, that in order to understand the other things they want, you have to get over that first barrier because you can't really have the discussion about the preferences at the next level. But the idea of flexible, simple, stress-free access to care seems to come through overwhelmingly in the work I've been involved in over a very long period and in other studies that have gone on in this area. And I think that's got very important implications for the way we fund and organize access to care. It was put to me by one comment I liked very much around this, where someone said, it's bad enough being in this position, don't make it worse. Don't add on to the problem of having a challenging set of problems, that you have a challenging approach to solving them. It's bad enough being in this position, don't give me the additional hassle and difficulty of getting access. In certain circumstances, palliative care seems to extend life, and there's certainly been good evidence from a number of different studies that in the right circumstances, a switch of intent from a more curative intent to a more palliative intent is associated with people living longer. And that's, of course, entirely unsurprising, but it's quite difficult to pull it out of the evidence because the evidence, again, has been grown up in very complex circumstances. But, for example, many years ago, I was involved in a systematic review of the role of bisphosphonate treatment in advanced breast disease. And of course, a lot of people with breast cancer were being poisoned by the hypercalcemia, and it's not surprising they weren't doing very well. But all the studies in the review were too small to show an effect. But you put them together, and they showed a life-extending effect of the sort of amount that would make a pharmaceutical company rich. Of course, it didn't make any researchers doing systematic reviews rich in that way. But I'm giving that as an example because sometimes the evidence around the life-extending effects of the change of intent get lost a bit in the fact that studies tend not to be powered to answer questions of that sort, and therefore it's only in the reviewing of evidence you tend to get that kind of question comes forward. But we know that essentially, a lot of treatment with curative intent is dangerous, so it's not entirely surprising that you're getting these kinds of effects in some cases. But it's obviously dangerous to say palliative care extends life, because in some circumstances it clearly doesn't. But nevertheless, there are circumstances where it almost certainly does. So, from this starting point, and me saying essentially it's all very complicated, we don't know, and in some senses can't know some of the evidence we need. What do we know about who should get what? Well, certainly we know quite a lot about the preferences people have for styles of service. And by styles, I mean things like the easy access, the flexibility, the approach that is clearly centered on the individual needs of individuals. And I'm increasingly of the view that the evidence is beginning to weigh up that in many cases it doesn't matter so much what is done, it matters more that it is done in particular ways. And that's not to say that there aren't better and worse ways of doing things, but what seems to be of primary importance is the approach and the attitude and the availability and the accessibility. Because studies that have looked at people with apparently similar needs who get access to very different styles of palliative care services don't on the face of it show up very large differences in the satisfaction or the self-rated quality of life of the individuals concerned. But there is a very clear picture that people are looking for that style of access and that style of delivery that is centered around their individual needs, and they don't feel they're just part of a production line process. I noticed one of the airlines this morning when I was going through the airport was advertising, "We treat you like a passenger, not a boarding pass." I was on that airline and I didn't actually notice the difference, but I was glad that they were thinking of me as a passenger rather than simply carrying a piece of paper from one side of the Irish Sea to the other. Clearly, and this theme about sort of hassle-free access, I think is something that we can take as an important component. And I was very interested to hear about the Coordinate Care initiative, because that seemed to me to be all about trying to reduce the hassle in the accessibility to care. And it seemed to me to be entirely in line with the kinds of things that the evidence is showing. Interesting question around choice. Is choice something people want? And what seems to be coming out of this is, yes, people want choice if they feel that they are empowered and capable of making choices. And they don't want to be forced to make choices where they don't feel they're in that position. So again, like in so many other areas in palliative care, we've got to understand that it isn't going to be simple. We can't have simple rules saying, yes, we need to improve people's choice. We've been doing some work with people with ALS who are in their early stages of contact with the service. They are in pretty good shape. They are mentally pretty good. They're typically quite young. they will have a very bad trajectory of symptoms and problems, but in the first instance, they were very keen to be involved in decision making, and they felt very competent to do so. And I thought it was an interesting contrast to some other patient groups where there was more of an interest in ensuring that good decision making happened rather than being enthusiastic about making decisions. So I think that to a large extent, the evidence as it currently stands is almost in the words of the song, and maybe seeing it's after lunch, I should set this to music. I'm seeing some skeptical looks in the audience. Maybe I won't set it to music, but it's a bit about it's not what you do, it's the way that you do it. And I can see also that most people are too young to recognize that as having come from a song. So who should pay what? Now, one of the starting points of all of this is, of course, we should all pay for palliative care. It's obvious because we all do, and nobody else is going to. Ultimately, it's the population that pays for services for the population. And we get ourselves tied in knots about how we should pay and when we should pay for services. But actually, in the end of the day, it's always us that's doing it anyway. And frankly, I'd rather be robbed at a time that robbing me didn't do me much harm than being robbed at a time when it stressed me out. So I think one of the things we really need to do is to try and move this discussion forward. Ultimately, we are going to pay. The question is, how can we do it in the way that minimizes the pain and the harm and the difficulty and the hassle? And one of the things that is endlessly depressing about almost all political discourse on who should pay what for services is people keep thinking that it hurts you less if you make it complicated, if you make it expensive to organize, if you make it totally full of hassle. And I was very depressed. You know, I left my job in London because I couldn't bear Tony Blair, and I had to get out of the country in protest against him because he had gone more right-wing than the people I'd previously voted against. But and this idea that somehow we should all make a contribution, and I arrived back in London today and see the headlines in the paper about GPs want to charge 25 quid each time you go and see them. And this is to discourage people from not turning up at appointments or something like that. I just went into a decline because this argument should have been resolved 35, 40 years ago. We know that that's not a clever way of putting in place barriers that are going to be useful. We know it'll put in place barriers that are not going to be useful. And one of the key lessons we have around who should pay is not who should pay at all, it's how should the people who pay. And it's quite clear that there are huge advantages in managing the payment system so that it doesn't appear on the radar at all around the time when services are being accessed. People constantly and consistently express a preference for ease of access that doesn't have, it's not so much the financial barrier as a cost, it's the financial barrier as a hassle and a constraint that they're fighting against. So therefore, the payment system should be as invisible as possible, and it should cause no delay. It's also important that it shouldn't push people down the wrong pathways. The other thing you get with charging systems is people going to the wrong place because it's cheaper for them. I had a great example of this with a man with serious mental health problems in Ireland who was going to a private hospital once a fortnight for treatment. And it was costing around about €1,000 a week for his care, but it was being paid for by his private insurance. And if he had had the same treatment with the GP, it would have cost him €55 a week. And it would have cost the rest of us nothing much. But he, of course, went where it was the cheapest for him, even if it was hugely expensive. And he said to me, I may have mental health problems, but I'm not stupid. And I think we have to recognize that people will follow the incentives that are there. So, where does this leave us? Well, we do still have an awful lot of work to do. And I think it's got to be more sophisticated work in which we try to understand what are the features of palliative care that are most important, in what circumstances, for what groups of people, how can we most effectively individualize the access to services around things that are going to be useful and appropriate. And how can we measure more effectively what we mean by appropriateness? And we have to recognize, I think, that we move from allowing people to think of palliative care as a thing to thinking about it as lots of things that have similar values and similar qualities, but nevertheless, it's an approach rather than a set of specific services. And as we move into the more complex management of the delivery of care, and I think the discussions earlier around how generalists and how general healthcare professionals get pulled into this process, we need to recognize that it's going to be an awful lot of different things, and we've got to work out how we can manage the complex needs being matched by complex interventions and sets of interventions, and based on better understanding of what value we get from what components. And we shouldn't be looking to answer questions like, is palliative care cost effective, any more, as I was suggesting at the start, than we should say, is surgery cost effective? The other thing that seems to me to be important here is that people only die once, with possible exceptions of James Bond, but we only die once, and we as individuals, but also as families, tend not to be able to share and use our skills a second or third time. And I think there's a real problem of capturing the understanding of the experiences of individuals and their families in the context of that learning being lost frequently. I had a brother with Down syndrome who gave me a huge amount of experience of the health and social care systems. My family lived in the west of Scotland, and we found 14 different statutory schemes that provided support for his care. What we don't know is how many we didn't find, obviously. We found 14 different sources because he was unemployed and he was disabled and he was severely disabled and he had mobility problems and severe mobility problems, etc., etc. But the thing that really depressed me at the end of it is I couldn't bottle our knowledge and say to the next person with a family member with complex needs, here's the kit, here's how to do it. Because I became really good at knowing how to care for a 47-year-old person with Down syndrome and the following 15 other problems. But getting that knowledge into the decision-making processes, I think, is a real challenge. The style and approach seems to be crucial, and this is around the kinds of barriers. It's also around the qualities that we expect the services to have. And we should devise ways of paying for palliative care that avoid extra stress and suffering. And I think I really want this to be my key message, that when we're talking about paying for palliative care, and we're talking about managing access, the one thing that can damage and probably undermine our activities almost more than anything else, if you allow these systems to have the sort of complexity and the characteristics that make people think this is yet another difficulty I've got to overcome in the context of having lots of other difficulties I'm being asked to overcome at the same time. And if you have been awake, thank you for your attention.